I would like firstly to thank the organizing committee for inviting me to present this interesting lecture. So what the Department of Endoscopy should know in COVID-19. The current coronavirus disease, COVID-19 pandemic, has affected routine endoscopic services across the gastroenterology community, which led to the diminution of the service. Endoscopy departments face a significant risk for diffusion of respiratory diseases that can be spread via an airborne route, including aspiration of oral and fecal material via the endoscopes. Being highly infective, SARS-CoV-2 put the healthcare workers in clinical departments performing endoscopy in great challenges during this pandemic as being highly susceptible to getting the infection. In fact, several studies have discussed the infection prevention and the control measures that must be implemented to increase the patient safety and prevent the nosocomial outbreaks and protect the healthcare workers to ensure the rational use of a limited PPE. So the question about whether to stop or to perform, as several endoscopic societies and expert groups have offered recommendations and position statements for endoscopy during the COVID-19 pandemic, such as EHGE, ESGE, and ESGE. Several GI societies guidelines recommended ceasing the elective procedures during the pandemic to decrease the risk of the infection. Different recommendation guidelines have been recently released to ensure the smooth reopening of endoscopy units and resuming the elective procedures. One of these studies were done by me and my colleagues in the Gastroenterology Research Hub, which was published in November 2020 in the World Journal of Gastroenterology, about the barriers of resuming endoscopy services across Egypt. We performed a survey with a multi-center from all over Egypt, endoscopic centers, and we found out that 34.5% of the centers reported significant shortage of staff during the SARS-CoV pandemic, especially in nursing staff and specialist doctors by almost 80%. This was related to two factors, either the reallocation of the staff and medical, the reallocation of staff and medical equipment to the surge in demand to manage the suspected and confirmed COVID-19 cases. The other cause was that some of them got already infected due to the frequent exposure to infected patients. So what are the problems of withholding the service? The prolonged suspension of routine endoscopic services during SARS-CoV-2 pandemic has a significant implication on diagnostic endoscopic services, such as the delay of diagnosis and management of cancer patients, especially cancer colon, and the expansion of the waiting lists across the world. So how to control the risk of transmission of COVID-19 in an endoscopic unit? Endoscopy should still be regarded a risky procedure, as endoscopic procedure demand very short distance from the patient to personnel. The ways to risk of the risk control, according to ESGE position statements and EHGC guidelines, fall into three main points. Number one was the protective personal equipment, the PPE, and the patient risk code. Number two was the infection control measures done in the endoscopy unit. Number three was the patient selection. So what about the patient dress code? How should the patient dress while performing an endoscopic procedure? All patients entering the endoscopy unit should be invited to wear a surgical mask. In addition, those who are classified as intermediate or high-risk patients should wear a surgical mask and gloves. The surgical mask has to be removed just before commencing the procedure. What about the endoscopy personnel themselves and their dress code? All staff involved in endoscopy department are invited to follow a standardized precautions as a measure for optimal infection control. All personnel should keep a reasonable distance from every patient during all steps taken before the beginning of the endoscopic procedure, such as the informed consent signature, the vital sign recording, the patient instruction, etc. It is mandatory to wash hands with soap and water or alcohol-based hand rub before and after all patient interactions. A very crucial part of the infection control is how to wear the PPE. The first PPE to be donned on is a hairnet. The proper hand hygiene should be performed using alcohol-based solution. The second PPE to be worn is the gown. In case the gown has a back closure, a second operator should assist the first one. After the gown, donning a filtering face piece, such as N95, FFP2, FFP3 respirator is recommended. It is crucial to perform a fitting test after the equipment has been put on the face. If not available, a surgical mask would do the job with increased risk of transmission. The next step is the goggles for eye protection. Gloves are next. Users should consider 2 pairs of gloves, one inner pair of gloves covering the skin up to the wrist, and the outer pair of gloves is the real working hand. How to remove the PPE is an even more essential and crucial part of the entire procedure that needs to be carefully carried out. The gloves are removed first because they are now contaminated. Hand hygiene should be performed again. A new pair of gloves should be worn to prevent self-contamination and continue the procedure safely. The gown should be removed using a second operator to assist the for gowns with back closures. Eye protection should be removed next. When removing the goggles or face shields, touching the front part, which can be contaminated by droplets or particles, should be avoided. After that, removal of the respiratory protection comes next. It is important not to touch the respirator during its removal. The hairnet should be taken off now. The last PPE to be removed is the latest pair of gloves worn, which may be contaminated. After the gloves removal, hand hygiene should be repeated again. What is the role of the negative pressure rooms in COVID-19 outbreak? Despite the suggestions of ESGE to perform endoscopic procedure in negative pressure rooms, in most endoscopy facilities, this is not available. Therefore, it is advisable to equip at least one endoscopic room with a negative pressure system to be used for all patients with respiratory symptoms or confirmed COVID-19 patients. When this is not feasible, we recommend performing endoscopy on patients in another room located outside the endoscopy department, which has this facility. Reprocessing the flexible endoscopes and endoscopic accessories is an important part of the infection control. It should be done according to the European Standard 14885. When all currently reprocessing guidelines are strictly followed, the risk of transmission of any kind of viruses is extremely rare or non-existent. Reinforced training sessions and personal meetings on the importance of strictly following endoscope reprocessing policy is highly encouraged. How to decontaminate the endoscopy room itself. The cleaning process should include cleaning of all surfaces in the procedure room, followed by proper disinfection. Non-critical environmental surfaces frequently touched, such as bedside tables, bed rails, should also be considered heavily contaminated and should be thoroughly disinfected at the end of each procedure. The decontamination policy for endoscopy rooms should take a standard room disinfection policy, should be kept in rooms when non-COVID or low-risk patients undergo endoscopy. In negative pressure rooms, a delay about 30 minutes is suggested between patients before we enter a new patient into this room. In the absence of negative pressure rooms, we suggest that it should be at least 1 hour before we enter another patient in this room. So the critical question, which GI endoscopy procedure should be done and which one should be postponed? According to the ESGE guidelines, the patient scheduled for GI endoscopy procedure should be divided into urgent procedure or elective procedure. If there is an urgent procedure to be done, the patient should be following a patient risk classification according to the COVID-19 case. If the patient is highly confirmed or this is a low-risk COVID-19 patient. If the while judgment of elective procedures, we should follow to evaluate the morbidity and mortality risk of GI disease versus the risk of COVID-19 transmission. If the risk of GI disease overweigh the COVID-19 status, then the patient should be performed and with risk stratification. If it's not high, the GI morbidity, then we can postpone this patient. This is how we stratify the risk according to no symptoms or high symptoms of COVID-19 and the PCR confirmation of COVID-19. And for each, we can perform a certain protection through the PPE. The indications for endoscopic procedures according to priority, according to ESGE, they suggest that we should also always perform acute GI bleeds, foreign body.
1 minute.
Sorry? Okay, I'm just finishing. Acute GI bleeds, foreign body, obstructive jaundice, or acute ascending cholangitis. Other cases should be judged case by case according to the priority. And some other cases, such as endoscopic surveillance for, endoscopic treatment of esophageal low-grade dysplasias, duodenal polyp, ampulectomy, band ligation, if non-emergent, should have a lower priority to be performed. Indications that should always be postponed are the surveillance for cancer, post-endoscopic resection, irritable bowel-like symptoms, screening for any cancer, or bariatric endoscopic procedures. So our take-home message is a challenging time for the world as we endoscopists and physicians have additional responsibility of protecting our patients and ourselves. The COVID-19 pandemic has led to restrictions in endoscopic volume all over the world. The staff shortage, recovery, and availability of COVID-19 designed rooms are the most important barriers against resuming the service. Increasing working hours and dividing endoscopy staff into teams may help to overcome the current situation. Strictly maintain the infection control measures and PPE, proper use using written protocols and dedicated meetings. Individual clinical judgment and local resources may lead to alternative perspectives regarding which procedure and patient are to be prioritized and when to resume a more regular endoscopy procedure schedule. Finally, the level of commitment and the amount of individual effort that everyone will contribute for preventing infection dissemination will help in creating a solid and durable barrier against this deadly virus. And thank you very much for listening.